This video will focus on some of the key interventions that we use to target shame-related beliefs in cognitive therapy for PTSD. Trauma can lead to changes in a person's self-perception, either through shattering their assumptions and self-beliefs or by confirming already held negative self-beliefs. It can also lead people to feel ashamed about how other people might view them if they knew what had happened. People may feel ashamed about some of their own reactions during a trauma. For example, if they lost control of their bladder or they became sexually aroused during a sexual assault. They might also feel ashamed about how other people will perceive the trauma, what happened during the trauma and their own responses, or the fact that they have PTSD. Where people have distorted views of their own responsibility for a trauma, they're also likely to experience feelings of guilt. Please see our training video on working with guilt for further information. Multiple traumas can lead people to develop strong, overgeneralized negative beliefs about themselves, such as I am bad or defective. This may be especially true when the traumatic experiences occurred at a developmentally important time in their lives. It may also be that trauma later in life activates or confirms pre-existing, long-standing negative self-beliefs. Shame can also be linked to humiliation and mental defeat, particularly when people have been traumatized by other people maliciously, especially during a prolonged trauma. Please see the training video, Working with Degradation, Mental Defeat and Low Self-Worth for more information. Shame in PTSD has two sources. Firstly, it can be part of re-experiencing. When matching triggers are present, this triggers unwanted memories and/or corresponding feelings of shame. For example, a woman who was raped might re-experience feelings of shame that she had during the time of the trauma in response to a matching trigger such as physical contact, like a hug from a family member or a friend perhaps, or being physically intimate. Secondly, some patients have distorted appraisals about what it means about them that they responded in a particular way during the trauma, or that the trauma happened to them at all. For example, we know that it's completely physiologically normal and natural to become sexually aroused during a rape or a sexual assault because it's a reflex. However, most patients won't know this, and therefore they may view any sexual response during a rape or a sexual assault to mean that they're dirty or disgusting, and they fear that other people would view them in this way if they found out what happened. People may therefore withdraw socially and not talk about what happened with anybody else. This unfortunately prevents them from finding out how other people would actually respond and would actually view them, and therefore maintains their distorted appraisals. Social withdrawal may also increase rumination and self-criticism, which again maintain the patient's feeling of shame. There are three maintaining factors for shame. Firstly, the trauma memory itself. Secondly, the appraisals that link to both the trauma memory and its aftermath. And thirdly, the dysfunctional behaviours, including withdrawal, rumination and self-criticism. This video focuses on the range of techniques used in cognitive restructuring that target shame-related appraisals. Please note that when the targeted appraisals are from the time of the trauma, the updated information is inserted back into the memory through updated reliving or narrative work. People are unlikely to openly talk about the things that they feel most ashamed about in relation to the trauma, or to name to you that they are feeling ashamed, mainly because they're feeling embarrassed or they're fearful about what you might think of them as their therapist. There are therefore things that we can look out for as the therapist, such as observing the patient's behaviour in the session. They may look away or look down while they're talking about the trauma, particularly key parts, hotspots in the trauma. Or they might talk about themselves as feeling awkward or silly or exposed. They may use labels about themselves such as weak, useless or inadequate. And some of these might also appear in the questionnaire measures that we use, such as the PTCI. In terms of non-verbal behaviour, patients often look away or go very quiet or still, or they become quite aggressive when talking about the worst moments in a trauma. We might also notice that they talk about being very socially withdrawn and not talking about the trauma, and this may also indicate shame. For example, a man that our team was working with, who was raped, went very quiet and silent for a while during the reliving at a particular point, and when the therapist asked him about it afterwards, he just looked at the floor and couldn't say anything. The therapist asked him whether he'd had an erection himself at that moment in the trauma. This was the case, and the meanings then elicited were that he must have wanted it to happen and he must be gay, which they could then discuss in therapy. But the key thing here is that the patient never said, "I'm ashamed this happened." The therapist had to gently spot the behaviour and take a guess to sort of break the secrecy here. Questionnaires such as the PTCI also has items that are helpful, and the information sheet, the psychoeducation information sheet that we give out, has a section on shame that can be another route into talking about feelings of shame. Finally, sexual trauma is especially associated with shame, so we need to be especially alert to it then. Here is an overview slide of all the ways that we work with shame in cognitive therapy for PTSD. Please note that this is not a linear guide, and we often move around to different items at different times in therapy, but overall therapy will usually cover these different stages. The therapeutic relationship is key when working with PTSD, and particularly so when working with shame. The therapeutic relationship with shame is often a crucial vehicle itself for cognitive change. Open discussions are really important before or during an assessment to acknowledge different therapist and client characteristics and how this might feel for the patient. For example, it could be really difficult for a woman who's been sexually assaulted or raped by a man to then work with a male therapist. Where possible, patients need to be offered the choice, if it's available, to work with an alternative therapist and to choose whether or not they want to work with a male or a female therapist. Patients need to feel safe and to be able to disclose their feelings and particular parts of the trauma at their own pace. We need to acknowledge how difficult this is and how brave they are to tell us what happened and how they feel about it. Therefore, all of the characteristics in therapy of being warm, empathic, and non-judgmental are key. The fears that patients will have about what other people will think about them and about their trauma will play out with us as therapists. Therefore, telling us anything can be an implicit or perhaps explicit behavioural experiment. It can be helpful for us to acknowledge this. Well done for telling me all of this. How did you think I was going to react? How did I actually react? What did you make of that? And what can you learn from this? How might this translate into the rest of your life and your other relationships? At this point, we may often hear sort of yes buts from our patients. For example, yes, but you're a therapist, you have to be nice to me. Again, we could respond with something like, well, maybe so, but what is the evidence that you have talking with other people and people you trust in your life? And how can we find out together what actually happens? A further point is for us as therapists to be aware that there may be perceived risks for our patients to developing a good working relationship with us. Specifically, if this is the first trusting relationship the person has developed for some time or in their whole life, then they may not wish to risk it by telling us the whole story. They might have a belief that if you really knew about it, then you would think badly of me. Or if I tell you all about it, this is going to spoil our relationship, it's going to contaminate it, and you will reject me. So we really can't assume that having a good therapy relationship will mean that automatically people will disclose information to us. There are a range of cognitive techniques that we use to restructure distorted appraisals around shame. This is a long list here of all the different interventions that we can use. We will look through the remainder of these techniques in this training video, starting with pie charts, using imagery rescripting and surveys, and then moving on to behavioural experiments, and then how to work on long-term negative self-beliefs using techniques such as positive data logs. Later in the video, we will look at how to address self-criticism using compassionate imagery. It may be that there are clear hotspots linked to shame of the worst moments during a trauma that are elicited during reliving. Sometimes patients may talk openly through these hotspots, where others may avoid doing so. It's therefore important to ask whether the patient was holding back at all after the initial reliving, and to ask whether there were particular parts of the trauma that the patient finds really difficult to talk about or think about. It may be that key details are disclosed later in therapy when the person feels safer and more trusting in the therapeutic relationship. Let's look now at an example of an enduring sense of shame that links to a key hotspot in a trauma memory. Here we will look at Joanne, who was involved in a serious car crash. After she was cut away from her car, she waited for a while for the helicopter to arrive to take her to hospital. While waiting for the helicopter, she wet herself. This information had not come out during initial relivings of the trauma. The therapist and the patient had been doing an updated reliving of a key hotspot where Joanne thought she was going to die. After this hotspot had been updated with the new information, the therapist noticed that Joanne seemed overwhelmed and skipped over the reliving to being in the helicopter. The therapist therefore gently slows down the memory and sensitively asks Joanne to go back into the memory to help identify a new hotspot that is linked to shame.
And then they put me on a stretcher and they put a brace on my neck and my head, and they put me in a helicopter. And then we go to the hospital, and then...
Okay, that's really good work, Joanne. So if we could just stay with that last part. So they put you on a stretcher, and they're putting you in the helicopter. Can you tell me what goes through your mind and what happens?
I really need to pee, but I can't move. So I wet myself. It's really embarrassing. I feel really ashamed. I should be able to control my bladder.
Okay, you're doing a really good job, Joanne. So you wet yourself and you feel ashamed and you think you should be able to control your bladder. What else goes through your mind?
That I'm disgusting. So embarrassing. Yeah.
And are these thoughts that go through your mind at the time of the trauma?
The worst meaning that Joanne has about this hotspot during which she wet herself is that she's weak, pathetic, and disgusting. As part of cognitive restructuring, the therapist gives normalizing information as soon as possible. She starts by using Socratic questioning to explore possible reasons why people wet themselves during trauma, and then gives some key information to help the patient update the distorted appraisal.
So what may be some reasons why people may wet themselves during a trauma or a very frightening moment? Should we brainstorm these?
Yeah, I can try.
What reasons come to mind why someone may wet themselves during a trauma?
Well, maybe if their trauma was quite long, then they might need to pee anyway. But then if you can't move because you're injured or something, then you might end up wetting yourself.
And were you injured?
Yeah.
And was your trauma long?
Yeah, it was a few hours.
What may be some other reasons why people may wet themselves during a trauma?
Well, maybe there's something about a trauma that makes it difficult to control your bladder.
Yes, that's right. Emptying a full bladder is an automatic reflex when the bladder is full, but our brain has learned to override our desire to pee by keeping the muscles that prevent emptying very tight. During a trauma, our body goes into fight or flight mode, and the fear center in our brain overrides those that control the bladder, so we're much more likely to wet ourselves.
Okay, yeah, I didn't know that.
So it seems that when we're scared, it's completely understandable that we would wet ourselves because we're more likely to lose control of our bladder or our bowels.
Pie charts are a common intervention for helping people consider other causes of their behaviour during a trauma, which is linked with shame. Working together, therapist and patient generate factors that contributed to the moment that the patient feels ashamed about. They then together assign percentages to all of the factors, starting at the top and ending with the patient's distorted appraisal at the bottom. This means that when we get to the patient's appraisal, there will be less percentage available to assign to the patient, which helps to reduce the sense of self-blame. Here again is the pie chart that Joanne and her therapist have drawn out, assigning the percentages given by the patient. Looking at the allocations and the pie chart together can often help the patient reduce the distorted belief. However, often while people can understand logically in their heads that self-blame is not justified, in their hearts they may still feel it. We need to bring this information into the memory through updating to help them believe it more emotionally in their hearts. Please see the video Updating Hotspots Linked to Shame on the main Oxcadat Resources website to see how Joanne and her therapist used the information developed from the pie chart and a later survey to update the shame-related hotspot shown earlier, and then insert the new information into the memory through updated reliving. Please see our training video on using pie charts in the main part of the Oxcadat Resources website for further information about how to use pie charts. Imagery rescripting is another helpful technique used in updating memories associated with shame. We can ask patients to think of ways that their update can be represented through an image, which the therapist then helps the patient to develop in richness and vividness by bringing in detailed sensory information. This technique is demonstrated by a role play in the training video addressing a sense of contamination or disgust in cognitive therapy for PTSD. Here is a brief excerpt of this role play, demonstrating how the patient is guided to generate a new image that includes her updated meaning of a hotspot and when she was forced to give oral sex during her trauma. Please see the whole role play to see how the patient is then guided to link the new image back into the memory using updated reliving.
Once, and there was a steam room with aromatherapy. So the steam was, I think it was eucalyptus or something like that. Anyway, it smelled lovely and fresh, so you could breathe it really deeply, and it was like it was infusing my whole body with the smell, which was really relaxing and refreshing. I could stay there all day.
That's brilliant. Excellent. What a great image. Lovely idea. So you can imagine being in that steam room, breathing in the steam and the eucalyptus, and just notice that taste and the smell. So is the semen taste disappearing as you imagine that?
Yes, it's like the steam cleans it all away.
Good, excellent. You're really good at this. All right, just hold that in your mind.
The length of time that it takes to shift a patient's sense of shame will vary from person to person, and it often depends on whether the shame is long-standing or whether it's linked to earlier memories. Please see the video examples in the Working with Degradation, Mental Defeat and Low Self-Worth training video, where the therapist and patient work together to use imagery rescripting to change how the patient responded to the perpetrator, and in effect changes her ending of the hotspots. For example, in this video, she puts on her clothes. She tells the perpetrator loudly to get out, which is not something that she did during the moment of the trauma. For some people, we can use Arnold Arntz's work on third-person imagery, as we may need to bring in somebody else other than the patient to change what happened in the trauma. For example, this may be someone they trust from the here and now, perhaps even the therapist, or it might be somebody from the past, such as a kind grandparent or a teacher. This can be particularly helpful when the patient finds it really difficult to show themselves compassion. While the technique here is slightly different, the core underlying principles are the same, to help change and reinforce meanings through the imagery brought to mind. We can also encourage patients to use flashcards outside of sessions when they feel an intrusive sense of shame, often linked to a trauma memory. We can further encourage patients to show themselves compassion in response to an intrusive sense of shame. For example, as well as using then versus now when a shame-based memory is triggered, we can encourage them to stand up, stand tall, and give themselves a butterfly hug. Surveys are a useful technique that can help patients reappraise a range of negative shame-based beliefs in PTSD. The survey might consist of a range of questions related to the patient's negative beliefs. But most often, when working with shame, we and the patient write a vignette together based on their experience and then send the survey out to responders to ask for their thoughts and feelings about the patient's experience. It is important here that we bring in specific questions targeting the patient's self-beliefs. Therapists might need to encourage patients to add in questions about the perpetrator, as their focus is much more often on themselves as being bad or damaged, following a sexual assault or rape, for example. And we can help them shift their focus onto the perpetrator and asking responders, what do they think about the perpetrator's behaviour? How bad or damaged do they think they are, for example? It can also be really helpful to ask responders what they would say if a friend told them this had happened to them, to elicit more compassion. We can also encourage our patients to complete the survey themselves, imagining they are reading about this trauma as if it happened to somebody else. This can often facilitate much more compassion from the person and help them to see the trauma in a different perspective. Please see the training video on doing surveys on the main Oxcadat Resources website for more information on how to do surveys. Here is an example survey for somebody who was raped. Here you can see we've written out a vignette together with the patient before we've designed some questions again with the patient of key things that we want to ask responders, challenging her specific beliefs. This vignette has some key information about what happened during the trauma, a little bit of background information, and how the perpetrator had behaved before the rape took place. It also talks about how Anaya had been withdrawing from other people, believing that she was worthless and that she brought it on herself and that her friends would agree with her if they were to find out what happened. And here are the questions that the therapist and Anaya developed together. Starting with a very open question about what do you think about what Anaya went through, and then quickly focusing in on her specific beliefs that she has about the trauma. For example, that she's dirty, she's damaged goods, she's worthless. Asking responders to comment on their answer as well as rating their belief from 0 to 100. Later, as you can see, we've brought in the question around the man's behaviour. What do we think about the man who raped her and what he did? And the final question being a question to elicit compassion around, imagine if Anaya was a good friend of yours, what would you say to her? As mentioned earlier, social withdrawal is common in people who feel ashamed about their trauma. And we gradually address this through reclaiming your life or rebuilding your life assignments. Surveys can be very helpful in encouraging patients to engage more in social activities. They can also be very helpful in encouraging people to disclose the trauma to people they care about. Surveys may be an important and helpful first step towards talking to other people in the patient's life about what happened. We can therefore set up specific behavioural experiments that follow on from the survey once the belief has been loosened a bit that maybe people won't reject me after all. Here is an example of a behavioural experiment that Anaya set up with her therapist following the survey. As you can see, the aim of the experiment was to tell one of her good friends about what had happened, and testing out the prediction that she had that her friend would say it was her fault, she shouldn't have invited him over so soon. She'd think I'm disgusting and damaged, and I'll know this by she will look away, scrunch up her face. So the experiment was to invite a friend for a walk, tell her what had happened, and see how she responds. The response here in the outcome was obviously a very positive one. The friend had been very kind and compassionate, given her a hug, and said she was so sorry that it had happened for Anaya. Naomi, the friend, had also talked about what a horrible guy this man was and encouraged Anaya to report the incident to the police. She did not think it was her fault. The key learning in this experiment being that maybe other people don't think as badly of me as I do, and that this was not Anaya's fault. It was his fault. And a more generalised belief around maybe I'm more acceptable and worth something than I think I am. The final key point here is to encourage patients to continue doing further behavioural experiments to further work on their overgeneralised beliefs about themselves after the trauma has occurred. So the next plan is to tell another friend about what happened. Where patients present with overgeneralised negative self-beliefs, there are some key additional techniques that we can use. The prejudice metaphor is a technique to help patients realise that their negative self-beliefs operate like a prejudice against themselves. It also helps them identify how they have cognitive biases that maintain their beliefs through only focusing on information that fits with their beliefs, while discounting, distorting, and minimizing information that do not fit with their beliefs. Continua encourage patients to challenge their black and white thinking and identify a more balanced alternative belief. Positive data logs then build on this information and encourage patients to keep a daily log of evidence that fits with their new belief. Please see our training videos on using the prejudice model, Continua, and positive data logs in PTSD on our main Oxcadat resources website. Self-criticism is extremely common in PTSD and often goes hand in hand with rumination. Patients can spend long periods of time ruminating about why traumas happened to them and asking what if and if only questions with a highly self-critical voice. For example, why did I listen to him? I'm so stupid. If only I wasn't this weak, this wouldn't still be bothering me. Paul Gilbert talks about an internal shame spiral, whereby people can be with us in the room, and yet they're very much in their heads dwelling and beating themselves up. This may be particularly problematic for people who have experienced multiple traumas or interpersonal traumas at developmentally key periods of their lives. These processes will clearly maintain their distorted appraisals, but it also stops them from being in the window of processing when we're attempting memory work. In this situation, we may need to bring them back into the room and help them reduce their self-criticism and rumination. With regard to memory work, having here and now reminders is essential where people are prone to self-criticism and rumination. Our training video on rumination has lots of information about how to help people label when they're ruminating and how to redirect themselves into the here and now and focus on something more meaningful to them, such as reclaiming a life activity. This next role play focuses on using compassionate imagery to address self-criticism. This is a brief excerpt of a longer role play available on the Oxcadat Resources website. The role play features Jackie, who developed PTSD following rape and domestic violence over a number of years. In this clip, you see the therapist guiding Jackie to imagine what she would say to her sister if she had experienced the same traumas, and then asks her to speak to herself in the same way as she would speak to her sister. Please see the full video on compassionate imagery on the site for more information, along with the accompanying video on writing compassionate letters to reduce self-criticism. You're doing so well, Jackie. And what a loving sort of thing to be saying if it was Izzy. You know, you didn't deserve this. It's not okay what he did to you. You're a beautiful person. It doesn't say anything about you as a person this has happened to you. Okay. Jackie, do you think we could bring some of that back to you? You said you'd give Izzy a hug. Could you give yourself a hug right now? Can you give yourself what we call a butterfly hug? Could you try and give yourself some of that warmth? How does that feel?
It feels a bit weird. But yeah.
Okay, so rubbing your arms, yeah, because you might rub Izzy's back or something, or her arms, and giving her that hug and kind of give yourself a squeeze. Can you try saying to yourself some of those things that you said to Izzy in the same voice, the same warm, reassuring, loving voice, Jackie?
Okay. It doesn't mean anything about you, me. It doesn't mean anything about me. That he did those things. I didn't deserve those things. It doesn't mean that I'm defective. I'm not defective.
Well done, Jackie. You're doing so well. I wonder if we can bring in some of the other things that you said to Izzy when you imagined this was her. You know, for example, that she's fine, she's okay as a person. So I wonder if you can bring some of that in now, saying to yourself something like, I'm fine, I'm okay as a person, I'm going to be all right, I'm beautiful, when you're ready.
That feels harder.
Yeah.
I can try.
Brilliant. And keep giving yourself that butterfly hug, Jackie.
I'm fine, I'm okay. I'm okay as a person. I'm beautiful, I guess.
This video has talked through how to identify and work with shame in cognitive therapy for PTSD. It is mainly focused on cognitive restructuring interventions. Please see our accompanying training videos on guilt, rumination, and degradation, mental defeat, and low self-worth for further information.